over time. So I work in the NHS UK basically in London, but also represent Sadiq International Virtual University. That is my brief intro, which of course is available on the LMS as well. So I'm going to talk about medical education over time. It's been a long journey. Medical education per se started very late. Education has been a long process. Now, we know from history that the ancient teachers from Galen and Hippocrates to Henry Gray, I'm sure you must have read Henry Gray's book of Anatomy, which I had to read and memorize, thanks to Mr. Flexner during my early days of medical education. And Lister, of course, the modus operandi was apprenticeship. There was no formal teaching. You had to learn by a process of close contact and long, endearing and enduring relationship with the teachers. That went on for ages. Two of the greatest in the history of medical education that I've come across reading through the history is Galen and Avicenna. I mean, Galen, of course, is very well known. Everybody knows about Galen. In the Asian literature, you will find this name as Hakim Jali Nus, which is proverbial in character. And Avicenna, of course, was famous because he was a polymath. He wrote on everything that was there. His book, The Canon of Medicine, was was a part of curriculum education activities in Europe until the 15th and 16th century. If you look at history of Avicenna's profile, one is amazed that this man could do everything, right from chemistry to teaching medicine in terms of practical apothecary to developing various amalgams and what have you. He was also a mathematician and a philosopher and theosophist, a great, great scholar. But there are lots of others. Education does not belong to one category, one person. It's been there. Knowledge has been there for millennia, I would say. And it's been there for a long, long time in India. And of course, China, they were there before the Arabs and the Iranis came over. So it's been there. Europe's formal education started way back in Middle Ages, but this is probably needs correction, that the rise of the universities in northern Italy, like Padua, is what the literature says. But I also come across this very interesting reference that the first formal university was established in 859 in Morocco by the name of Al-Karuni. But before that, if you look at the history of education development through universities, Plato might be called the first person who established the academy in 387 BC, which was followed by Aristotle. Of course, we know that Socrates never wrote, never documented his whatever he said. He just went on saying, which is documented by Plato. Socrates did not establish university. And before Socrates, there used to be people called theosophists like Thales and Protagoras, and one of them, the most famous, was Pythagoras. They did not have institutions as such. The institution was established by Plato in 387 BC and then Aristotle in 334 BC, which is called the Lyceum. I also came across this very interesting literature that the knowledge that spread over time, Shanti Niketan in 1921 started the concept of open education in India. It was established by Rabindranath Tagore, the famous writer, author, and Nobel laureate. Now I'll come to that in a minute about the open education. But what happened was that from 1100 until the mid-19th century, two kinds of medical educators or teachers of medical professionals were available in the literature or in the world to practice: academic doctors and practically trained practitioners. Still, we see, if you look at the profile in the USA or UK, 85% of doctors are basically trained practitioners who know how to deal with the patient's illness. Only 5 to 7% will go into academics. And in those 5 to 7%, only 1% will be a thorough researcher, even today. So this distinction has been there. Now, people have been trying to amalgamate academic medicine and practical sciences. A lot of people are doing it. It becomes very difficult because academic medicine is totally different to clinical applied sciences, because academic medicine involves a lot of research and funding and international travel and what have you. But practical approaches like treating a patient is relatively easier and simpler. So people opt out for the easier option. Now, we also know through the history that surgeons were called barber surgeons until the 17th century. They used to be traveling practitioners, ship surgeons, tooth extractors. and wax removers from the ears. Even today, you see them in different parts of the world. Now, the academic doctors are purely nerds. They're knowledgeable people, but have very limited practical experience. They could only prepare lotions and potions like the old-fashioned Hakims do in India, Pakistan, and the Arab and the Irani world, but they were very good in theoretical knowledge. Even today, we see that. Unfortunately, that's the whole story, that the profile of academic doctors is more nerdish rather than practical. Next, please. Next, Mubashir. The so-called practitioners learned the art of apothecary through, now this is important, through observation, osmosis, apprenticeship, and hands-on training. Now, osmosis is the fundamental formula. What they learn, they observe, they visualize through their senses, they absorb into their brain and percolate it through the system into their practical habits. So they learned not by teaching, but by observing, by using their sense of smell, observation, etc. And that process of osmosis, even today, this process continues, especially in the traditional curriculum. Osmosis and long association in the form of apprenticeship. I'd like to mention here that hands-on training is coming back. Only yesterday, I read in the paper in the UK that instead of having the GCSEs and A-level and O-levels, they're thinking of starting hands-on training that is practical diplomas, which are basically problem-solving methods so a person can get a job, earn his livelihood, not purely theoretician that who cannot apply his theoretical knowledge into day-to-day practice. Now, this has been practiced for 1,000 years or even more. Next. So there was no formal teaching. It was just a principle of long association with the guru, with the master, with the mentor, that they learned the art of apothecary or medical treatment. Next. Quality of medical education was poor. So it was taken over by state authorities whose primary aim was to ensure and improve public health rather than teach or train the physicians. So public health was important because those were the days when the contagions were there. There were lots of deaths, plague and leprosy and what have you. So that was more important in terms of treating the patients rather than teaching the physicians to become good doctors. That came much later. Next, please. In Europe was in darkness. And of course, before that was the era of the Arab and the Iranian golden era. And before that, Indian and Chinese, they had prospered in medical fields across the world. And you have lots of names like Al-Farabi, Al-Biruni, and Avicenna, and Al-Hashim, and lots of people, right from India to China to Central Europe and up to Spain and Andalusia. There were people who were training and teaching in different 600 to 800 years. So Europe, can you go back? Yes. Between 1809 to 1950, the first of half of the 19th century, medical education gradually started to reform. What happened was that a philosopher called Voltaire, when he brought about the radical change in thinking of French people, the French Revolution followed, and the guilds were to control the medical profession. They were dissolved, and medical education was then given certain rights of developing their own academic affairs. Next, please. In the Netherlands, as the decree of 1850 shows, that the nature of academic medical curriculum was established, but nothing was stipulated about their content. They were given, the professors were given a right that you can choose your own curriculum. There was no uniformity, no generalization. It was more specific, relevant to a particular teacher, what he wanted to teach and when he wanted to teach. And the teacher was examiner as well as the teacher himself. Medical education in the 19th century, particularly in Europe, and of course, America just began to come into light. It was a total mess. Contagions, like I said, were there, like leprosy and plague and all those things. Apothecaries, soothsayers, and magicians used to cure plague, leprosy, and cholera. And then the source of polluted water was found in the present London and Soho, where that fountain is still there. It's a historical thing. If you ever come to visit London, go to Soho and see where they found the source of cholera. And then they started talking about hygiene, that it's not really the air, it's the water that is a causative factor. And then pasteurization followed, and health started to play an important role. America was equally chaotic because those were the days when they were having slavery and all the bad things in the world. And there was nothing in terms of medical education. There is a man that is historically recorded, Carnegie, Edward Carnegie. He was a miner from Scotland, from Dunfermline. He moved to USA and made lots of money. But what he did was that he became a philanthropist and established what's called the Carnegie Foundation. He had suffered as a miner in Scotland because UK used to be in miserable health. And I have a picture that I'll show you in a minute. So he realized the importance of health, hygiene, and medical care. And therefore, he hired an educator, not a doctor, an educator to reform medical education. Next, please. Carnegie Foundation hired this instructor to investigate, and that was the term of reference, to investigate the nature of healthcare and ways to improve in the US. And that was a gentleman called Abraham Flexner. He was born out of the need of time. Next, please. He was an important factor. And Abraham Flexner wrote down an extensive report, which was published in 1910, and he based his medical curriculum on biomedical sciences. He was given a task to produce a doctor who was multifaceted, multi-purpose. Like a doctor could be a GP, could be a surgeon, a gynecologist, a pediatrician, obstetrician, forensic doctor, and what have you. So he was given that task. And because that was the era of contagions, plagues, etc., etc., so health authorities did not matter. What was needed was that you had to develop a doctor who would go to remote areas and treat these conditions. So his curriculum was based on biomedical sciences. What he forgot to mention, or didn't have the time, in fact, to mention, is the role of hygiene, preventive medicine, and ethics. Next, please. Right, so he's definitely an evolutionary thinker and a philosopher and educator, but very controversial. If you look at his profile, he was even considered to be a racist of form because he closed down a lot of schools, medical schools in the Afro-American communities, what they used to use a word which I cannot say, the N word. So he was controversial, but he was given a task which he accomplished rather faithfully. Next, please. There were many faults in his reports, and everybody has a right to criticize. This is my view. I may be wrong. His review was that you should concentrate only on the disease, not on the health, not on the holistic pattern, not on the lifestyle, not the psychological factors, not the moral issues. Just cure a disease. And that is exactly what the traditional curriculum was built on. Next, please. Next. So the traditional curriculum that I was taught in, and I taught for so many years, that was developed on the base of Flexner report. It was based on biosciences, ignoring humanities, or preventive medicine, as I said earlier. Next, please. Preventive medicine was not even considered to, but I recall when I was a student in the 60s and 70s, preventive medicine in the form of hygiene had just begun to be included in the medical curriculum. We had fantastic educators in Dow Medical College who used to concentrate on preventive medicine, and it compliments to them that 50 years ago, they were thinking all those things that are coming back in today's life. What was important was that the concept of traditional curriculum was that one divided scientific medicine from public health. They were never integrated as such, which is what was done much later. Next, please. So it was overloaded. Everybody knows, and it's nothing new about it, that the traditional curriculum, we had to cram up, rote memorize Gray's Anatomy, Samsonite's physiology, and this pharmacology, and that kind of college. So I remember when I first came to England to do my first years, I went to see Professor Loss, who was the teacher of anatomy. In the state categorically, Gray's Anatomy is not to read on a regular basis. It is an encyclopedia. Go and keep it in the library. Read something simpler, like dissectors and what have you. So that was the problem with the traditional curriculum. It was also teacher-centered. The teacher decided what to teach. It was not based on students' learning process or learning desires. And it also lacked, and that is a fundamental thing I keep pestering about, is humanities. It lacked human touch. Next, please. American Medical Association, which is a strong body in the US, a lot of people go to America after doing their USMLEs. It did not establish educational standards for internship programs until 1919. As late as that, and the quality of the education and training was poor. as late as 1930, they had different categories of internship and fellowship. Fellowship came much later. Internship and residency programs, some lasting 3 or 4 months. Next, please. It was actually William Osler who decided that categorization, standardization, accreditation had to be done. And he came up with this concept that there should be a pattern, a pyramid. Many interns, few residents, and at the top should be a single chief resident who could stay there 5, 7, or longer years. Now, of course, it has changed over a period of time, and now you can have a chief resident, and then on top of that, faculty member, assistant professor. You could be an honorary faculty, or you could be actual faculty. In the UK, the concept of being a professor was non-existent until very late. There used to be 1 or 2 professors. The rest were all basically clinicians, not even educators. I'll come to that in a minute. Next, please. This was the state of affairs in the UK. On the extreme left on slides, you will see a picture of London in 1800 with cholera and plague and leprosy and leper colonies, everything's there. Barber surgeons came up with the concept of establishing their own college, which is called the College of Surgeons of Barber Surgeons. Then they fought with each other, and that was, I think it happened in 1368, when they came up with the proclamation that a Royal College of Barber Surgeons should be established, which then went on to 1493, when the Royal College of Surgeons was established, of which I have been a humble student in 1970s. And the picture on the other side shows the early formation of the NHS, which was a need of the time. People were dying, miners were dying, typhoid, typhus, etc. The gentleman that you see was a miner's son who became a minister, Evan Bevan. Was it Bevan? I'm forgetting the name, but he's the gentleman who started the process of NHS. I think, yes, Bevan. Attlee was the prime minister and Bevan was the health minister, who said that the state needed a healthcare service based to help everyone, provide free healthcare at the first point of contact, and service based on need rather than affordability. And that is exactly the formula 50 or 60 years on. NHS was established in 1948. It was service-based. Education was not a part of it until much later. Next, please. So it was a service-based, not education-based. I studied on my own. I had to pay for my education, for the courses, etc., etc. It was much later when Tomorrow's Doctor, the famous document, was published by GMC in 1993, when they realized that in order to get the optimum of physician, you have to educate them as well. So then they started thinking about formalizing education in the form of lectures and teaching and clinical sciences and skill-based and whatever. It came very late, as maybe 1995, 96. It was just basis service-based. And now, of course, education has taken up an important role. Of course, the story of the subcontinent and old British colonies was the same. That whatever was taught in the UK was transported or transplanted to these countries like India, Pakistan, Bangladesh, Malaysia, Taiwan, Uganda, and African countries. It was the British reflection of the education system. That is why that was a major problem. When my teacher said something about an appendiculum like sausage shape, I didn't know what a sausage was. I had never seen a sausage in my life. Or when they talked about the liver abscess being like anchovy sauce. I had never seen anchovy sauce until I came to England. So it was, and of course, they never knew about TB. The books did not mention about tuberculosis. They talked more about conditions relevant to their societies. So there was a radical change that was needed. And that came much later when people who came from the second crop of educators in India, Pakistan, Bangladesh, Uganda, etc., when they realized that what we've been teaching is rubbish. We should develop our own books. We should write our own books. We should concentrate on diseases affecting our societies. That is how it transformed. Next, please. And of course, in the US, it was a miserable situation. The curriculum was overloaded. Nobody knew what was happening. Next, please. They realized that the curriculum has been overloaded. So some people went back. There was this gentleman by the name of Frenette who was an educator, primary school teacher. Mind you, medical education is only a reflection, is more like a wing of education per se. It was the educators who developed the psychology of teaching, psychology and learning process of teaching, evaluation, etc. And we learned from them. So this gentleman came up after the First World War, and he could not speak or whatever. He said we had to devise a method of continuing to teach in his village in France. Next. So what he did was that he said that, okay, you come up with your answer, your questions, your answer, you learn between yourselves, and I'll facilitate. So this gentleman was the first person who thought of PBL, but it came as formally in medical education introduced in McMaster University in Canada in late 60s. Next, please. And those who've been to Ottawa and these places, Canada is a beautiful country. This is a picture. Next, please. Campus and the name of the two authors. Can you go back once more? Go back. Yeah, these are the people who wrote the first article ever about PBL, Harold Barrows and Robin Temple. Of course, there must be many more. This is the one that comes up as the pioneers of PBL system. Next, please. Next. PBL, as you know, I don't have to teach you, all educators, you know, familiar, but just to highlight points, it's an active rather than a passive learning process. So a student has to be a lifetime learner. He has to learn. That's exactly what we're trying to inculcate this through the school. Interactive education. It has to be interactive. Next, please. It is not a problem-solving per se. Problem-solving method has come up. And only recently, when I met Dean Said Abu Zaira of Kufa University, he said that he is working on problem-solving method in Kufa University, as against PBL, which is international. There are a lot of people doing. I need to learn that from him. Next, please. So PBL, of course, we know that the trigger points have to be developed through a small group discussions, scenarios have to be identified. So teachers facilitators have to do a little bit of work, but it's basically concentrated and focused in the thinking process, deductive process, culmination in a certain problem-solving activity. And that is PBL is all about, that you're familiar with. Next, please. Subsequently, they do studies and they learn, go back, and it's a process that you're familiar with. I don't have to go back into it, but you know how it works. It takes a few weeks to solve a particular problem in a module. Next, please. Now, this is where I'd like to highlight an important thing. I have always maintained for many, many years that the American system may be faulty. But one good thing that I've learned over there is that they have this 4 years of liberal arts before you enter a medical school. Now, that period of 4 years gives you insight into humanities and psychology, into philosophy, into human touch. It makes you a better, more accomplished human being. And I've seen in various universities that I've worked that a student who comes with this 4 years of liberal arts is more accomplished and manages much better as a doctor, as a physician, without belittling the position of other doctors. But there is a sense of there is a slight difference between the achievement levels in both categories. And I would like to promote this system to the educators all over the world. That look at it, you don't have to apply. But 4 years of liberal arts where you teach humanities may be much better than teaching zoology or botany or subjects which are otherwise irrelevant. Next, please. So PBL, they've realized after due course of time that it was incomplete without community engagement. It was superficial and impractical. So they said, we should come up with another solution. Next, please. So the evolution continued and community-oriented medical education was thus born. I was a part of this initial process. If you go to the next one, please. Its aim was to produce community-oriented doctrine. This is a fantastic idea. Way back in 1990s when it first came, we said, this is the answer. Because you're talking about conditions which are relevant to a community. You want to apply that knowledge in practical fields. But what you have to do is you have to send this student to the community to look after the person, the family, not just the person, the whole family, in health as well as in disease. You follow the whole pattern. But it has certain impracticalities also. And that was the very simplest challenge. I'll go on to the next slide and talk about a friend of mine who was a pioneer of comb. Bashir Ahmad was a famous professor from Sudan. And I've just seen there's a gentleman who was in this group, Dr. Abu Bakr from Al Jazeera University. Bashir Ahmad did this experiment and successfully completed the implementation of Qom project in Al Jazeera University in the Sudan. But people always objected. And one of the questions that he pointed out in his famous letter, I worked with Bashir Ahmad in Dow Medical College, where we established a WHO center in 1995. He was a great scholar, a great teacher. We used to share things. I mean, I was a teacher of medical ethics and he was a teacher of medical education. We formed a perfect combination. I still miss him very much. Anybody, if he knows him, please convey my compliments to him. Now, they say that Qom is really not practical because the third rate medical education, you're producing, those were the days when China was producing barefoot doctors. They said, you're producing nothing but barefoot doctors, which is wrong. Community gets involved. Next, please. So these were the objections raised, and Bashir has documented that in his paper. And they also said that's not scientifically based because you're just talking about soft sciences. You're not talking about basic or fundamental science like anatomy, physiology. That is wrong. You have to integrate all the subjects together. You cannot teach anatomy separate from physiology, separate from biochemistry. The integration came much later after Bashir Ahmad had left. Anyway, so we went on, and this was then the experiment in Dow Medical College and other parts of the country in Pakistan, which was then published as a WHO report by Lubna Beg and Kausar, two of the great educators from Pakistan. It is available in the literature search. This was then followed by community-based education. That's the force in medical education involving the community. They said, let's try to engage the community through their needs, find out the needs. And this is exactly what we are trying to do through our international programs. Look at the needs of the community, look at the needs that particular community needs, and try to develop courses, curriculum, teaching style according to the compatibility and needs, rather than imposing ourselves from different areas. Anyway, this went on. Next, please. This is an activity that takes place within a community, not just within a community like community society, but also involving health professional services like GPs, like community centers, like primary centers, like secondary centers. The tertiary centers were not involved in it. You had to refer these students to tertiary care hospitals for education, clinical sciences and things. Next, please. Of course, this new thing that's come up, competence-based education, and I strongly feel that this is going to take up because competency is what is needed. We don't need theoretical knowledge, we need practical applications. This is what's happening in the UK. More and more concentration is being given to the competence of a person, be a physician or a surgeon or a plumber or a technician, engineer. You have to have competence to solve the problem, to resolve an issue rather than be a theoretical master. Next, please. The journey continues, and this CBE is continuing to activate itself. It's becoming more and more educational in process, and people are learning through interactive process. And if you look at the literature that's coming out in the recent times, Medical Teacher and all the journals, magazines, they're talking constantly about competency-based education. Next, please. It focuses on outcomes rather than emphasis on abilities or promotion of learning, remembering through rote memorization. Next, please. I'm about to finish. Next, please. This is the new one, outcome-based education, that you look at the outcome. What comes out of the entire activity is what's important. The whole thing, the entire thing is that you should be holistic in nature and should be able to solve the problem of person, resolve the issue. You have all the theories in your mind, but if you cannot resolve the issue, then it's meaningless. You can give all your knowledge to computers. They have taken over. Next, please. And of course, this is community-based learning, which is also a part of community-based, competence-based education. That is a new activity that's going on. Next, please. I'd like to finish it if I can. Next, please. This is important. Evidence-based medicine was never taught until 1980s, 1985, 86, 88. Around that time, I came to know of evidence-based medicine when I used to travel to UK for learning experiences. And I met this gentleman from South Wales University or Manchester, and he talked about it. I didn't know about it. Now, of course, everybody knows that unless the medicine is evidence-based, it is useless. Paracetamol versus ibuprofen, both are good, but which one is better? You cannot go on hearsay. You have to have evidence. Everything should be evidence-based. Next, please. This is a diagram that I borrowed from one of my colleagues, I think Shahid probably, or Hasnain, that traditional thing is pedagogy, of course. Andragogy is adult learning, which was introduced by Knowles, and we'll talk about it when we talk about theories of learning. Heterogogy is that you have to be active, lifelong learner. And technogogy is a new term that has just come up because now technology is being embedded in medical education as we speak. Next, please. COVID-19 has changed the complexion of the game altogether. We didn't know what to do. I mean, remember 2020, January, February, March, April, nobody knew how to teach. We suffered moral trauma. Teachers, people, students, parents, everywhere. We didn't know what to do. You didn't know how to cope with this problem. Education was lost. Health was more important than educating and teaching. But then, within a period of time, like we started CV program in March 2020, we said we have to teach, we have to tell people how to cope with this problem, PPI or no PPI, we have to, and that is how the systems have evolved. And what has happened is, next please. The COVID has led to certain radical changes in medical education. Face-to-face became impossible, so we had to find different ways. Remote learning has become the order of the day. Hybridization and blended learning has become a new norm. And that is why we are learning through, I mean, this global academic activity is a fine example. It is a blessing in disguise, a silver lining in the darkest of clouds that COVID-19 came and spread across the world in 2020. The silver lining has to be these remote technologies and the e-learning process. Next, please. Next. So e-learning has come to here. This is being used in the healthcare and the NHS for evaluation, assessment, audit, appraisal, what have you. But it's being used in all other factors in different fields of life. E-learning has become a norm. Next, please. There are 5. This is Dr. Shole's slide that probably she'll talk in a talk that I borrowed from her. The e-learning saves time and money. With online teaching, it's much easier to access across the world. I mean, this is the quality of e-learning and modern education, that the geographical borders, the time and space have been transcended. You don't need covered corridors or silent quadrangles or what have you. Open education, let knowledge be free. All the shackles or the fetters or the chains which tied the knowledge down for thousands of years, right from the days of biblical knowledge to modern days, they have been totally broken. Now knowledge is free. It has come to your door. You don't have to go to university or to college. This is a fantastic time that we're living in. We're fortunate to be living and enjoying these modern times. Next, please. So new norms are going to be, at this an evolutionary process, remote learning, machine learning, micro-learning that Shahid will talk about when he has time, and mobile learning that Hasnain will talk when he gets time during the course. But these are new norms that are developing in medical education. We have to learn them fast. Next, please. And what is happening is technology is becoming more and more embedded in medical education. Technology through artificial intelligence, virtual reality, augmented reality, and this is the latest, cyber patients. Dr. Karim Kayumi is the inventor of this technology. He's based in Vancouver. And it's an amazing technology. You don't have to have patient for clinical. Everything is already fitted, filled in, computed into the cyber patient somewhere in the space. And any kind of 240 odd conditions that we see in clinical, you can talk, teach, learn through cyber patient. This technology, Dr. Kayumi has kindly given us to us as a service to humanity. It is expensive, but he's been kind to give us, and SIVU is utilizing it through different communities, like, for example, in Kufa University and also in Karbala and other places. Next, please. So the word for technology embedded education is technogogy. So you have to be a technogogue. If you do not imbibe technology now, you'll be left behind. Those physicians who do not imbibe education will become like in the olden days, there used to be people when the computers came in, people who were scared of computers, they will left behind. There will be physicians, but they will not be up to date with the knowledge and technology, which is being used constantly. And these are the changing scenarios. E-learning, e-meetings, e-research, e-publication, e-books. I mean, printed books are gone. Can you believe it? Nobody could even understand. Can you imagine that Encyclopedia Britannica will be stopped from printing. There's no print available. The last publication came last year. And the ebooks are taking up the entire thing. So in my view, sky may not be the limit. The life is going on. We're going to cyberspace. And this is what's going to happen. It's already happening. AI in the form of deep mind is being utilized in the NHS as I speak. And people are working every day to gather information. We're talking about Da Vinci codes and Da Vinci robots and what have you, and artificial intelligence, resolving a lot of issues. So education, rote memorization, you can give to the computer. Problem solving, creativity and thinking and critical analysis should be the human mind who should be doing it. Next, please. This is a man I particularly like you to read about, Edmund Pellegrino. Very few people know of him. He was one of the thinkers, the greatest thinkers of modern times. His lament was exactly what I lament about, that in order to be a physician, you should first be a good human being. It should not be sciences alone. We should be teaching and learning humanities and philosophy, because we're talking constantly with human beings and their psychological issues, their mental health issues. So he was the person who actually talked first, I think way back in 2004 or 5, that humanities should be a part. And this is my message to you. If you're an educator, you're a planner, you're a vice chancellor, you're an educator, try to include philosophy and medical ethics as a part of curriculum in the educational process. Zoology is good, but not as good, as effective, as useful in your medical sciences as philosophy would be. Next, please. And we should continue to learn. Look at the floods in Pakistan and the health and education disasters. Disasters are primarily health related. We have to learn to cope with them. Go out, reach out to humanity to serve them. What is needed, not applied sciences, but practical application. How to resolve the problems of people who are afflicted with disasters like this one. And I'll stop here. I think this may be the last slide. I'm grateful to you. There are many references, but I've just mentioned 2 or 3 which are relevant. Thank you for giving me the time and the honor and the privilege. Thank you. Bye.